Hello, my name's Snoop Suma, and I'm a
Afternoon, everybody. Welcome to the Pat Magee oral presentations, and we have 10 presentations today, and we're going to be starting with our first one from Anup Sumar, which is Contemporary Outcomes of Surgical Aortic Replacement, a high-volume single-centre study. So we could start the presentations, please.
Hello, my name is Anup Sumar and I'm a fifth year medical student at Cambridge. And over the last year, we analysed the surgical aortic valve replacement outcomes at the Royal Papworth Hospital in Cambridge. So over the last decade, the use of transcatheter aortic valve implantation, or TAVI for short, has gained a lot of popularity and has evolved. And there have been numerous multi-centre trials comparing the use of TAVIs with surgical aortic valve replacement, or SAVR for short, in high-risk surgical candidates and now increasingly in lower surgical risk candidates. And based on this, we thought it'd be good to analyse our surgical aortic valve replacement data from Papworth, which represents a high volume centre. And our objective is to see if SAVR remains an excellent treatment option for patients with severe aortic valve disease. So we retrospectively analysed 1,005 patients who were aged over 60 years who underwent isolated and primary surgical aortic valve replacement between the 1st of January 2015 to the 31st of December 2018. And this data was retrieved from the Royal Papworth Hospital patient databases and approved by their ethics team. We decided to stratify patients by surgical risk using the Logistic Euroscore 2 model as defined in the 2017 EACTS guidelines for the management of valvular heart diseases. And we defined low risk as less than 4 and high risk as more than or equal to 4%. And we compared our continuous variables using the Mann-Whitney U-test and our categorical variables using either the chi-squared or Fisher-Exact test. So overall in our cohort, 19.2% of patients had surgery on an urgent or emergent basis, and 97.5% of our patients were implanted with a bioprosthetic valve. This table shows our some of our key post-procedural outcomes, and to note are our low stroke and pacemaker implantation rates. And as we can see, our higher surgical risk group has statistically worse proportions of red blood cell transfusion, acute kidney injury, and ICU and hospital stays. This table shows our destination mortality and survival rates, and to note is our low 30-day overall mortality at 1.7%, which was statistically different between the two surgical risk groups, as was the data for 1 year survival and 2 year survival, as well as those patients being discharged home. And if we only consider our elective patients, our 1 year survival rate was 95.4% and our 2 year survival rate was 93.1%. We also plotted our patient survival data using the Kaplan-Meier method to 5 years post surgical aortic valve replacement. And as we can see, our high surgical risk group did statistically worse compared to our low surgical risk group in terms of survival rates. This table compares our high surgical risk group to the TAVI arms of 3 large multi-center trials. And this just emphasizes that surgical aortic valve replacement can be comparable, if not superior, in terms of outcomes of stroke and pacemaker implantation. And this is even considering when these large multi-center trials had strict inclusion and exclusion criteria, whilst our results represent real-world outcomes. It's also important to note that our results were superior compared to the surgical arms of these multi-center trials. And this is also supported by other studies in the literature. There are other studies showing that their single-center results are superior to these multi-center trials. Another thing to note is because surgical aortic valve replacement has been long established, we have a lot of data on its durability, its long-term durability, and structural valve degeneration, whereas the same can't be said for TAVI. and it seems that future studies will focus on looking and comparing SAVR with TAVI based on long-term durability. So to conclude, we show that excellent outcomes can be achieved with surgical aortic valve replacement, and it remains a reliable treatment option for patients with aortic valve disease. Thank you. Hello?
Thank you for that, Anoop. Can you hear me?
I can hear you.
Good.
Sorry.
Thank you for your good presentation. I think we're going to open the floor to questions.
Hello, can you hear me?
Oh, there you go, Betsy, yes.
Sorry. So I had one question. Thank you for that presentation. You obviously focus very much on the surgical aortic valve replacement from your unit. Why did you not look at the same data for your TAVI? If you're comparing surgical outcomes to a national data set or an international data set, why did you not look at your unit's TAVI outcomes?
So we did consider it. When I was discussing with my supervisor, it was so, I think the guidelines suggest that the TAVIs are for people who are high surgical risk or not deemed suitable for SAVR at Papworth. So we thought the comparison may not be necessarily the best. So we did consider it, and due to like time for data collecting and stuff like that, we decided not to. But I do agree that it would be good to show it from our centre as well. Then it can give more insight to that.
Well, it just gives an overall picture of what your centre's approach is to aortic stenosis, really. So it'd be nice to see that. Thank you.
Thank you.
If we don't have any others from the chat, I'm happy to ask one as well. And perhaps if you did have those results from the TAVI arm as well, can you think about how you might communicate this to a patient in terms of procedure and risk and what the options are?
I think it would be important to emphasize that there are options to a patient, and obviously not to kind of give your opinion without laying everything out there first. I would say that, I guess in terms of for patients, they want something that's not as invasive. They want something where they don't have to be in hospital for too long, probably, but also that does the job properly. So I guess depending on the patient's risk factors, what you would say would be affected, and how you direct and approach it to them. Some of the risk factors with TAVI that are worse, such as the pacemaker implantation and stroke, could be discussed, but also the fact that you won't have to be in hospital for too long, or generally less than surgery. I'm
just going to interrupt you there because I think we're quite short on time, but thank you.
Sorry.
Very good answer. Thank you for your presentation.
Thank you so much.
Will you move on to the next video?
Yeah, so our next presentation is by Ria Patel, and it is on gender representation of authors accepted for presentation at the 2020 Society for Cardiothoracic Surgery annual conference.
Good afternoon. My name is Alexandra, and I'm a third-year medical student at Bartender, London. And today I'll be presenting about virtual and augmented reality in cardiac surgery. So these two are three-dimensional real-world simulations, allowing users to directly interact with the simulation. There is a couple of objectives set in medicine for VR, and these are use of simulations to train and assess psychomotor skills, use of technologies to interact with medical imaging for surgical planning, and use as a simulator to rationalize surgical training and fitness to practice assessment, as well as use of VR to guide microrobots undertaking minimally invasive interventions. Here is a couple of specialties where it has already been implemented and used. And for our methods, we've performed a database search in databases such as Embase and Medline. Initially, we've identified 210 papers, and we've narrowed it down to 24 papers for our analysis. We have identified 3 areas where VR can be used in cardiac surgery. The first one being surgical teaching. So for undergraduate teaching, VR is a more efficient technique to gain new knowledge as practical skills. It provides cognitive motivation, and it provides improvement of recall of facts. And in postgraduate teaching, it is a tool to familiarize with the instrumentation and manipulation of instruments. It provides the expertise and proficiency via repetitive training. It also decreases the invasiveness of procedures and reinforces the surgeon's dexterity. In operative planning, which is another area we've identified, it can be used in pre-op planning, such as the Stanford Virtual Heart Project, which is a visual aid for families in pediatric cardiac conditions. Another one is a distraction therapy used for subjective and objective discomfort reduction. And another one is the 3D visualization of anatomical structures in VR. In terms of intra and post-operative planning, virtual reconstruction of surgical targets is one possibility. And this is the MRI images combined with 2D transesophageal echocardiography data intraoperatively. And the post-op option is the quicker cardiac rehabilitation post-surgery. And this is VR-enhanced rehabilitation versus no enhancement group. And the enhancement group has reached the therapeutic goals quicker. In terms of cost effectiveness, which is the third area we've identified, initially there is a cost barrier to using cardiac surgery. But the implementation is becoming more affordable. There is a long-term cost control and reduction of material wastage, and there is elimination of cost of cadaveric and animal tissue models. VR also allows for repetition of learning experience. So in terms of conclusions, we have concluded that VR and augmented reality are safe and effective training opportunities from undergraduate levels to specialty. They provide improvement of pain management and surgical outcomes. There is also a long-term reduction of costs in surgical management and planning, despite the high monetary input at the beginning of the investment, and overall improvement of patient safety, surgical training, and audit quality can be obtained by the implementation of VR and augmented reality in cardiac surgery. Thank you very much. Are you able to hear me now? Perfect.
Thank you, Alexandra. Sorry for the incorrect introduction, but yes, we've got some questions for you.
Perfect.
While someone else checks if there are any other questions, I can ask mine if that's okay. So you presented some of the evidence for including virtual reality in education. I wonder if you could talk a bit more about what you think the barriers are. Why haven't we used it yet? And the second part of that is, do you think COVID and the new ways of working and how we're all having to train virtually will have an impact on how much we use it?
All right. Yeah, so the first part about education. So we've looked into both undergraduate and postgraduate training. And the first thing is that it is being implemented more and more in postgraduate training because there are benefits of it. It's actually been seen that there are benefits in terms of the cost effectiveness and in terms of repetitiveness of training. But in terms of undergraduate training, we have to look into how specific and specialized VR is. So I think it's got a very high cost of implementation, and it might not always be the best way to teach students in undergraduate level. And also, I think it's more beneficial from what we found in the study that if you've got a certain amount of knowledge, it's very cost effective in terms of practicing and repeating the specific surgeries or procedures. And about COVID, I think this is something we've actually found out in the last year, that there are many more ways we can study online or learn remotely, and some of them we knew earlier, and some of them were developed last year, and some of them turned out really well. So I think the virtual reality will be becoming more popular, specifically in terms of this remote learning and coming back to the normal reality.
Thank you. Any other questions?
May I just make a comment that really interesting, it's the way forward clearly. And if you read The Future of Surgery or go to the Royal College of Surgeons of England website, there's a whole commission on the future of surgery. And my mind was blown when I sort of read it and all the options. So the future is really exciting, and you're part of it, Alexandra. So thank you.
Thank you very much. Thanks.
Okay, so
welcome. My name is Simonette, and my presentation is on the risk profiles and outcomes of patients undergoing surgical aortic valve replacements and transcatheter aortic valve implantation. A single-center experience. Severe symptomatic aortic stenosis, as seen in Figure 1, has a poor prognosis without surgical intervention. Surgical aortic valve replacement is the gold standard treatment for these patients. However, following the Partner 1A, Partner 1B, USCOR valve, Notion, Partner 2 and SATAVI randomized trials, transcatheter aortic valve implantation has now emerged as an alternative therapy for patients who are elderly and at extreme, high or intermediate risk for surgery. Indeed, the SCET's guidelines now recommend that in patients who are at increased risk for surgery, the decision between SAVR and TAVI should be made by the heart team, with TAVI being favored in elderly patients suitable for transfemoral access. With this as a background, this study aimed to evaluate whether there was a change in surgical patient risk profiles and outcomes between 2006 and 2016, and whether there were any differences between 2016 surgical patients and contemporary TAVI patients. The treatment for aortic valve disease has changed over a 10-year period as the fields of surgery and interventional cardiology have developed. We wish to document the state of intervention for aortic valve disease and to outline and identify differences.
Hi, I'm Bertie.
Welcome. My name is Simonette, and my presentation is on the risk profiles and outcomes of patients undergoing surgical aortic valve replacements and transcatheter aortic valve implantation. A single-center experience. Severe symptomatic aortic stenosis, as seen in Figure 1, has a poor prognosis without surgical intervention. Surgical aortic
Hello and welcome everyone, and I'd like to welcome you to my talk and presentation today on the study of gender representation of the authors accepted for presentation
Well, thank you, Ria. We finally got there, but it was well worth waiting for. I enjoyed that. If you don't mind, I have a question for you, and it's more of a personal one. I'm hoping that you yourself have come across some female role models throughout your education so far. Has that swayed your choices so far in terms of career?
Yeah, I think it has. You know, the whole thing about seeing a female role model is actually true. Unfortunately, when I had placement, I wasn't on a cardiac thoracic. I wasn't placed for cardiothoracic surgery, but I was on colorectal, and that was my first encounter with a female consultant. And it did actually. Well, for my BSc next year, I'm doing gastroenterology and hepatology, and I feel like that's kind of what sparked that interest, and it has really helped influence my decision.
Yeah, it's good. It's good to hear.
Thank you.
I wonder if I could jump in as well, as there's no others on the chat, but we talk about role models a lot, and it puts a lot of emphasis on identifying and finding these people who then have to shoulder the burden of inspiring everyone else while the men get to carry on just doing their day jobs. I wonder if you think of anything else apart from role models. Given the evidence that you've presented, which was really nicely done, what else could we do here to target apart from role models?
I think besides role models, actually aiming and conducting and doing more talks specifically targeted for the younger generation. So doesn't necessarily have to be about having a set role model, having a set mentor, but even seminars made available for people such as myself at university that wouldn't necessarily stumble across a conference such as this, just again to demonstrate the points that I made within my talk. I think that would be really beneficial.
Mel, can I come in, please?
Yes, of course.
Thank you. Thank you. I think excellent presentation. Thank you very much. And obviously more to do. And as Gillian alluded to, it is great role models. You know, we're all for that. And you're meeting on the screen, you're seeing many of the inaugural Women Insert Cardiothoracic Surgery team that will be announced very shortly. So, but I think you've answered the question really well in that it's not just the burden, or Jill, as Jill implied, it's really role models, vitally important, mentorship, etc. But it's also something that everybody needs to take responsibility for. So what are your thoughts on, and I'm sorry if I don't want to give you a difficult question because I'm not mean, I'm a nice person. Really, honestly, I am. What do you think the role is of the men in this story, and maybe a little bit about male allyship and sponsorship and all that kind of thing? Because it's great to be a role model. We love it. We're sort of accidental role models because we just happen to be here. But tell me what you think may help with some of the less fairer sex helping with this agenda. Thank you.
So I think, like you said, I think that the key point would be still spreading awareness of the fact that there is this disparity, because I feel like a lot of people are unaware. And then hopefully if, say, the male gender is more aware of this issue, then when it comes up in conversation, or when they're more aware of it in the back of their head, they could do things such as help incorporate females into the field, such as the mentor that works alongside me in this project. He was a male himself, and he did recruit me onto the project because he was aware of this issue. And I feel like little things like that built all together will help make a large difference.
Absolutely. Allyship and sponsorship is really important. Thank you very much, Melanie.
Thank you. Well done.
Thank you very much.
I'm a intercalating medical student, and today I'm going to talk to you about an audit that was done last year, and it's a single-centered study of perioperative transfusion in first-time cardiac surgery at the Freeman Hospital. So our aims and objectives were to review current blood transfusion practice within cardiac surgery, establish how many cross-matched units were actually transfused and how many were returned unused, and try and identify whether there are any patterns or patient risk factors for transfusion, and to assess whether current practice is appropriate or whether we could actually improve. So we collected retrospective data from April 2018 to March 2019. We gathered basic demographics such as age, sex, height and weight, preoperative hemoglobin and hematocrit, as well as transfusion data. We analyzed for patient operation, so we grouped them as all or first-time CABG, first-time valve, and others. Redo operations in patients with missing weight or height were excluded, as well as any other operation that's not listed above. So the data for 665 patients gave patient demographics as shown. The mean BMI was 28.8, the mean age was 68, the mean patient was a man, and the preoperative hemoglobin was normal at 136, as was the hematocrit. So overall, 28% of patients required a transfusion. As you can see here, the CABG and valve operations required the fewest transfusions, and aortic surgery required the largest number. So here we look at patients with a low hemoglobin, so hemoglobin of less than 120, gave a requirement to transfusion in 71% of patients. Whereas if you look at patients with a hemoglobin of greater than 120, only 20% required a transfusion. Further still, if your hemoglobin was greater than 130, then only 15% required a transfusion. So the CABG group was the largest, as we said, and this is a snapshot of that patient group. The patient group is fairly representative of the population demographics. So it was a man, the age was 68, the hemoglobin was normal, and the BMI was overweight. So in this group of patients, you can see the Freeman Hospital's normal cross-matching practice, which was to cross-match 2 units of blood per patient. None were being transfused, and 2 units were returned unused. So now if I draw your attention over here, as we said before, 23% overall required a transfusion in this group. If your hemoglobin was low, again, you can see it's a higher rate opposed to a lower rate if your hemoglobin was greater than 120. And there was a higher rate in patients with a lower BMI, as you can see. So looking at patients by BMI, the highest rate of transfusion was in a lower BMI. As you can see here, this actually is quite a small patient group, but if we were to take a BMI of less than 20, you still get 44% requiring a transfusion. So that still gives you quite a nice curve down to the lowest rates of transfusion in a high BMI. So overall, 75% of the cross-matched units were returned unused, as you can see in this pie chart. Whereas if we look at patients who had a hemoglobin of less than 120, 61% were actually used. This translated to a relative risk of 3.6 times for transfusion in patients with a hemoglobin of less than 120. And it was similarly high in the patient group with a BMI of less than 20, 1.9. So our conclusions, well, as we've said, if you had a low hemoglobin, you had the highest risk of transfusion. This risk was significantly reduced if your hemoglobin was greater than 120. Patients with a lower BMI seem to be more likely to require transfusion. And something that was picked up in this audit was that we were unable to differentiate between intraoperative and postoperative ITU transfusions. So I leave you with the question, should we routinely cross-match first-time patients or should we just group and save them? Thank you for listening.
Good presentation. Now it takes me back to my cardiac roots. I had just a quick question to kick off with. Are there steps that you're routinely taking for these patients perioperatively or preoperatively to make sure that their hemoglobin is over 120 before they come for surgery?
So that's actually something I was looking into, so preoperative hemoglobin optimization, and as far as I could tell, no. So patients that were presenting with anemia weren't being treated for anemia unless they were already being treated in the community. So that's something that has only just recently started to happen at the Freeman with colleagues that I was working with at the time.
Okay, thank you. Any other questions? Pharah?
Do you think it's, are you surprised that people with a much higher BMI need less transfusion? Do you think, does that sound counterintuitive? Or what are your thoughts on that? And vice versa, why the lower BMI have a higher transfusion rate? Thank you.
Thank you for the question. Yes, well, it was more of an observation that I found during the study. It's not really something that's been written about before. Whether it's actually a feasible finding, it needs to be researched further. It was something that I saw sort of just as I was processing the data, and I thought it'd be interesting to check whether it was statistically significant, and I did find it to be so. So yeah, it's just something that needs to be researched in the future. But yeah, you're absolutely right. It's not something that has been looked at before, and it doesn't seem to be something that anyone else has thought would be a connection before.
Sounds like there's a literature review coming at your way, Bertie. And it was interesting a while back when we had the Little Blue Book, not the recent one, or not the Little Blue Book is from Oxford and it's about sex, no, the Blue Book, cardiac surgery, that people with lower BMI did have a worse outcome. And intuitively you sort of think higher BMI and more comorbidities, etc. But it was the people with the lowest BMI that had the highest rate of mortality across cardiac surgery. So I think it'd be worth looking into. Thank you, Mel.
Okay, thank you, Betsy. I think you had a quick question.
Yes, a very quick one. I like the bike, by the way. So what does the unit in Newcastle have a policy for blood transfusion? Is there a protocol?
No, I don't think there is. Miss Booth, please correct me if I'm wrong.
Because I think just a tip, you could write a protocol. It makes a big difference. As soon as people are aware that you're scrutinising blood transfusion, the blood transfusion rate drops.
Okay.
What's the protocol in your unit, Betsy?
Sorry to interrupt, but do you know what that effect is called, Bertie, from an audit point of view? How does that work? And it's the Hawthorne effect. It's a very important one, and it works.
Okay.
Good point for quality improvement.
Can I just make a quick point as well? So we've had similar findings in Liverpool, and we've actually reduced our cross-matching now for straightforward first-time cases to 1 unit for patients who can be automatically cross-matched quickly.
We've written your next paper for you, Bertie.
Thank you. That's something I was proposing whilst I was there. So hopefully, yeah, we'll get some responses. Thank you very much.
I just love the way, Betsy, you think that if he writes an SOP, our anaesthetic colleagues will listen. I mean, that if you can tell us how to do that, then, you know, that would be great.
Next time.
That's a whole different session.
Yeah. Well done, Bertie.
Thank you very much.
All right, I think we're moving on. So I think we should have Simonette's talk now, and it's on the risk profiles and
Welcome. My name is Simonette and my presentation is on the risk profiles and outcomes of patients undergoing surgical aortic valve replacements and transcatheter aortic valve implantation. A single-center experience. Severe symptomatic aortic stenosis as seen in Figure 1 has a poor prognosis without surgical intervention. Surgical aortic valve replacement is the gold standard treatment for these patients. However, following the Partner 1A, Partner 1B, Uscore valve, Notion, Partner 2 and Satavi randomized trials, Transcatheter aortic valve implantation has now emerged as an alternative therapy for patients who are elderly and at extreme, high or intermediate risk for surgery. Indeed, the SCETS guidelines now recommend that in patients who are at increased risk for surgery, the decision between SAVR and TAVI should be made by the heart team, with TAVI being favored in elderly patients suitable for transfemoral access. The treatment for aortic valve disease has changed over a 10-year period as the fields of surgery and interventional cardiology have developed. We wish to document the state of intervention for aortic valve disease and to outline and identify differences in patient groups treated with SAV versus TAVI. All patients from a single center with symptomatic severe aortic stenosis undergoing either SAVR in 2006 and 2016 or TAVI in 2016 were included in this retrospective analysis. Hospital electronic records were reviewed to obtain baseline patient characteristics and clinical outcomes. A total of 491 patients were included in this audit of first-time SAVs in 2006 and 2016, and first-time TAVIs in 2016. In terms of the baseline characteristics, TAVI patients in 2016 were older with a mean age of 81. Across all groups, there were slightly more males. On average, the patients were under 30. TAVI used only bioprosthetic valves, whereas open surgery in 2006 used these valves 67% of the time, and in 2016, 72% of the time. The Logistic Euroscore is the European system for cardiac operative risk evaluation, identified risk factors which help to predict cardiac surgery mortality, especially in high-risk patients. This score was higher in patients receiving TAVI. Total number of procedures carried out in 2006 for SAV and 2016 for SAVR and TAVI. Both A and B show that more males undergo the surgery, and that TAVI is a procedure mainly conducted on patient more than 75 years old. Patient outcomes A shows symptom relief was similar between SAVR and TAVI. B shows that paravalvular regurgitation was higher with TAVI. Patient outcomes C and D shows that stroke and in-hospital mortality was similar between SAVR and TAVI. In this project, we aim to examine the baseline characteristics of patients being treated with SAVR and TAVI. Contemporary surgical patients have similar baseline characteristics to their 2006 peers. TAVI patients are older and at higher risk for surgery than contemporary SAV patients. Patients undergoing SAV had similar rates of bioprosthetic valve implantation between 2006 and 2016. The majority of patients treated with SAV and TAVI have relief of symptoms, and symptom relief is similar between SAVR and TAVI. Paravalvular regurgitation is higher with TAVI. In regard to key outcomes such as stroke and in-hospital mortality, contemporary surgical patients have similar outcomes to their 2006 peers. TAVI patients have similar outcomes to contemporary SAV patients. In conclusion, between 2006 and 2016 there has been no significant change in surgical patient risk characteristics and major outcomes. TAVI patients are older and have higher preoperative risk than contemporary surgical patients, but in-hospital mortality and stroke are similar. I would like to thank Dr. Cameron Dowling, Dr. Stephen Brecker and Mr. Robin Kanagasabay for their help and guidance. Thank you all for listening.
Okay, thank you for that, Simonette, and we'll open to the questions. Karen.
Yeah, sorry, just unmuting. Simonette, I'm sorry that you weren't able to give the version that you wanted to with you speaking, but I just had a question. Were you surprised by your results in the fact that you found that there was similar morbidity and mortality, and can you give any explanation as to why that might be, that you think, between the two procedures?
Sorry, I don't know if someone not the question.
Are you able to hear me okay? Simonette, can you hear us okay?
Maybe her screen's frozen.
I think she's frozen.
Just to say, everybody, we do recognise these technical difficulties. Please, bear with us, and don't worry, your performance is not being judged on difficulties, so don't worry about that. And we can come back and ask questions at the end. So maybe we'll sort out connection and then move from there, shall we?
I think just to add, if anyone does have any questions, please feel free to put them on the chat, and we can collate them later.
Yeah, I think we'll move on to the next talk then, will we?
Okay, yeah. So thank you, Simonette. We'll come back to you with questions. Mastectomy, does it make a difference?
Hello everyone, my name is Sabrina Mason. I'm a final year medical student at the University of Liverpool. Today I'm going to talk about pulmonary metastasectomy in the context of colorectal cancer and present data from Liverpool Heart and Chest Hospital. So pulmonary metastasectomy has caused a lot of debate over the years, and the question as to its impact on overall prognosis remains unanswered. Those in favour of it tend to quote around a 50% survival rate at 5 years. And this seems to be higher than the 25 to 40% survival rate for those with lung metastases who don't undergo treatment. However, a lot of the data comes from observational studies, and there's a lack of control data. So finally, the PULMIC trial was set up to answer this question. And it was a randomised controlled trial which compared pulmonary metastasectomy to active monitoring. However, the trial failed to recruit significant numbers for a meaningful statistical analysis. Other research has shown and been able to identify some prognostic factors, which include single metastasis, long disease-free survival, and a low CEA. However, these tend to be general prognostic factors which are associated with cancer survival rather than being specific to metastasectomy. So our aim was to examine the outcomes of patients at our centre following pulmonary metastasectomy for colorectal cancer. We collected data from a prospectively filled database, and from July 2013 to 2016, we identified 120 patients. Demographic and outcome data were analysed and survival curves were plotted. So the results. So the mean age of the cohort was 66, with 64% being male. The median ASA grade was 2, and the median performance status 0, and dyspnea score 0. All the procedures were carried out electively, and resection mostly consisted of wedge resections, although there were 32 lobectomies and 1 pneumonectomy. Around 50% of the procedures were completed by VATS, and the conversion rate was around 11%. So post-operative complications were low, and only 6% experienced any post-operative complications. These included lower respiratory tract infections, prolonged air leaks, post-operative arrhythmias, and reoperation. Looking at survival, so we plotted a survival curve, and it showed that at 90 days, survival was 99%. And at 5 years, survival was 45%. This was comparable to the results of the PULMIC trial. Our conclusions. So pulmonary metastasectomy for colorectal cancer can be performed safely and with a low mortality rate. Overall survival at 5 years following resection was 45%, which is comparable to the PULMIC trial and other large observational studies. However, it's largely been assumed that 5 year survival of these patients with lung mets is near 0. However, an updated analysis of the POLMIC trial has recently reported a better survival in the control group than was previously assumed, and survival at 5 years was around 30%. So the benefit of resection of these lung metastases needs to be questioned. Other research which has looked into the interval of disease monitoring has also found that there's been no benefit in early detection of these metastases and no survival benefit in increasing surgical treatment. So currently, a large trial is still needed to investigate the benefits of pulmonary metastasectomy. Any future studies should look to identify any prognostic factors which are specific to metastasectomy, and should also consider whether there's a role to compare surgical resection to stereotactic ablative radiotherapy. There should also be a role for to investigate quality of life, as most of these patients present asymptomatically from a chest point of view, and therefore a measure of the effect on patients should be made. I'd like to thank the thoracic surgical team at Liverpool Heart and Chest Hospital and Mr. Shackloth for supervising this project. Thank you all for listening, and I'm happy to take any questions.
Great, thank you for that, Sabrina. I think Karen had a question. Is this for this one, Karen, or shall I kick off? Yeah, well, you start. I've got a question as well, so you go.
No, sorry, I was just thinking that probably way more appropriate that you ask.
No, not at all.
Just wondering from the present, it was a really good presentation. Just wondering, given that POLMIC was difficult to recruit to, and the fact that it's for metastatic disease, how do you consent these patients to undergo this type of surgery?
Have we got Sabrina there still?
I don't think so, actually. That's what I was just looking. I think I should stop asking questions.
Can you hear me now? Sorry.
Yes, that's brilliant. Did you hear the question, Sabrina?
No, I didn't. Sorry, Karen.
Yeah, no problem. So the POLMIC study was difficult to recruit to, and because it's operations for metastatic disease, I just wondered, how do you consent to patients? Such you had one patient in there that had a pneumonectomy, and you talked about quality of life, and that certainly affects your ability to breathe after surgery. So how do you think patients should be consented for these types of operations?
Well, I think obviously when you consent a patient, you have to tell them about all of the risks of the procedure, which could include proceeding to pneumonectomy. And I think it's difficult at the moment. I think that's probably one of the reasons that the POLMIC trial struggled to recruit, is because some of the surgeons have, sort of strong views over which treatment patients should have, and some very strongly believe that they should go down the surgical route. So I think, especially if we have more data on this, it'll be easier to consent patients, because at the moment we can't say for certain, oh, this will improve your survival or it won't. And that's sort of the main aim of this treatment, is overall survival. So if you can present patients with that data, I think it will make these decisions easier one way or the other.
Thank you.
Okay, well, I had a quick question, which is slightly, well, could be inflammatory, but how many metastectomies is too many in one patient? What does your unit feel about them?
To be honest, I'm not really sure about that question.
Do they keep going?
Difficult is, I think I've definitely seen patients that have come back for a second metastectomy, but I'm not sure if over the time I was there, I'm not sure I ever saw a third, so I'm not exactly sure what their numbers are, and I didn't really look into that. But I think it's difficult as well, because there's I think we know that patients that have a single MET tend to do quite well, and then patients that tend to have multiple metastases, do have a poorer prognosis. So I think it's that middle ground, the ones that are sort of in the middle, let's say have 2 metastases, do we do surgery or do we not? And I think that's where the data is really missing.
Yeah, it's a very grey area, and I think you're pulled in all directions from what the patient wishes and what they hope for to get out of the operation, but also what the oncologists want as well, because quite often they want you to sort the patient out in terms of their mets. But yeah.
So Melanie, I still remember the name of the patient who had come back 6 times, 3 on the left and 3 on the right. Does that answer your question? I also...
Yeah, well, we still see them, and it still crops up. You know, can you possibly do this completion pneumonectomy on this patient? You're like, really? So yeah.
As a matter of fact, I remember when Gareth came back for his last one, he asked if he was going to be palliated, that he would come back to the ward. He didn't want to go to the oncology ward because he knew the thoracic ward so well at home.
Oh, bless him. Any other questions from anybody? No? Well, thank you, Sabrina. It's a good topic. Thank you very much. So let's move on to our next talk, which I believe should be by Toby Ball, and it's the activity of cardiothoracic surgery throughout the COVID-19 pandemic. Very topical.
I'll be discussing what has happened to the activity of cardiothoracics at Derriford Hospital over the course of the COVID-19 pandemic and what the drivers have been behind this. So COVID-19 has caused widespread disruption and cancellation of surgery and outpatient appointments throughout medicine. And we thought it would be good to establish the effects it's had on cardiothoracics at Derriford. We also wanted to look at the factors that have affected how this has happened. So we looked at patients who had cardiothoracic surgery between the 1st of April and the 1st of October, both 2019 and 2020, for comparison. The type of surgery was then found in the operative notes to either to be elective, urgent, or emergency. However, we found that the number of emergency cases were very low for statistical analysis, so we omitted these. And the capacity monitoring plan for Derriford Hospital was used to evaluate the waiting list numbers for outpatient appointments during the same period. We found that there were 33% less cardiothoracic surgery cases conducted at Derriford compared to 2019 within this period, with elective cases dropping 50% in total. As we can see from the comparison here, the total surgical cases plummeted in April 2020. This was as a result of the restrictions put into place regarding the cancellation of elective surgeries, as seen by the orange line. This has started to recover over the course of May and June and stabilised around August. But interestingly, when we look at urgent cases, there were more cases completed in 2020 compared to 2019, despite ongoing restrictions. So when we break this down, it becomes even clearer with the elective cases. There was only a single elective case conducted at Derriford in April 2020 compared to 44 in the previous year. We can see that that cases start to drop dramatically even between February and April as the prevalence of the virus emerges. Whilst elective cases increased again, they were not back up to similar levels of 2019 between July and September. Urgent cases, on the other hand, had a higher number of cases this year. And whilst we saw a dip in the levels around about April 2020 compared to 2019, we had increases of 82 and 113% in May and June, respectively. Overall, during this period, there was a 40% increase in the total number of cases compared to 2019. It appears there are 3 reasons behind this. Firstly, during May and June 2020, there was an increase in CICU bed capacity by 83%, meaning more cases can be completed and more beds can be found for these patients. Secondly, urgent cases weren't cancelled. And finally, we suspected that there were patients moved up from elective to urgent as a response to the cancellation of elective surgery. This is because clinicians felt that they couldn't wait any longer for their surgeries, and they needed to be moved up to urgent because they felt that they wouldn't have been able to conduct surgery safely and waiting for elective surgeries. With regards to patient waiting lists, we saw an increase in the surgical waiting list by 17% in April 2020. And this is thought to be due to the cancellation of elective surgery. It then reduced back down 19% through April and July, following the resumption of surgery and the cancellation of outpatient appointments. With this in mind, there was also a decrease in outpatient waiting lists by 25% between July and October 2020, even after the resumption of outpatient appointments. This suggests that there have been less referrals from primary care, and poses the question as to whether surgical cases are being missed as a result of the pressures of COVID-19 and the subsequent morbidity as a result of this. Unfortunately, it's difficult to compare surgical waiting lists as there was an initiative conducted in 2019 between July and October, as seen in the graph, drastically reducing the waiting list. However, this does raise the point that these initiatives could not be completed this year due to ongoing restrictions. So to conclude, we found that up to October 2020, there was major disruption in cardiothoracic surgery at Derriford, as we expected. But despite this, urgent cases increased as a result of the availability of post-operative resources and improved case workflow, with de-escalation beds becoming more available. Outpatient lists were also decreasing. And it's important to establish the cause of this, to ensure that there is not morbidity relating to missed surgical cases or barriers to healthcare as a result of COVID-19. This data is continually being monitored throughout 2021 to establish the ongoing effects of the pandemic on cardiothoracic surgery. Thank you for listening.
Thank you, Toby. Very topical and excellent presentation. And we're opening the question. Well, we're open to questions from the floor. I haven't seen any in the actual chat. So, anybody? There's Jill.
Yeah, just to emphasise, everyone, please do comment and ask your questions from the floor, so you don't have to listen to us all the time. But Toby, you just mentioned one of the big things during COVID, that we have this sort of lost population of people that we don't quite measure on the surgical side, and that's from the referrals, but we see them dropping for a number of reasons. And you mentioned that we have to look into that. How do you propose we do that?
Quite difficult because these cases are completely unknown and fly almost under the radar. I think it might be to see.
Toby, can you get closer to your mic?
Oh, sorry.
Yeah.
Can you hear me better now?
A little bit.
Okay, I'll speak up a bit. I was just saying how it would be really important to go and speak to primary care providers to have them see why potentially their referrals are dropping, to see if they have any reasoning, and if they don't, to look at the numbers and see how much it's decreased and just why we're missing these. It's really difficult, as you say, to understand why these numbers might be dropping, and actually to see how we can establish it. We can establish why they dropped.
Okay, great. Sorry, it's quite hard to hear you, but I think I got part of your answer there. So, and acknowledging that it's quite hard to do. The final part of my question, if no one else has any, is if we do have significant increases in waiting lists, which you haven't demonstrated, but lots of places have, and lots of other surgical specialties have, how can we address that, do you think? What kind of strategies are people talking about in terms of addressing that big backlog post-COVID?
I know that from my centre in particular, pre-COVID, as I mentioned, there was an initiative that happened in larger London hospitals where patients were sent up to London and surgeons to London to do these cases when they were available to, and it might be possible with restrictions lifted that these initiatives could happen again. As to actually what's happening, I'm not entirely too sure, but I'm sure there would be a case for almost sharing patients and kind of finding larger centres in our case to conduct these cases.
Okay, I think, yes, I think that's the end of the questions for you, Toby. Thank you very much for your presentation. Well done. And we'll be moving on now to Rishab. So hopefully we've got Rishab coming online with us, and he is going to be talking about are amiodarone and digoxin safe to use in post-cardiac surgery patients with concomitant pulmonary hypertension.
And thank you so much for this opportunity to present at the annual SCTS meeting. Our research aims to answer the question, are amiodarone and digoxin safe to use in post-cardiac surgery patients with concomitant pulmonary hypertension? As most of you will know, arrhythmias constitute some of the most common postoperative complications, and studies have shown that up to a third of all cardiothoracic patients suffer from arrhythmias. And although some of these are simply paroxysmal episodes, many do require medical treatment. And once identified, treatment regimes can vary from rate control using beta blockers to rhythm control using antiarrhythmics such as amiodarone and digoxin. The most commonly occurring postoperative arrhythmia is atrial fibrillation, and several studies have established the role of antiarrhythmics in treating AF. However, the drawback of this evidence base is that there's very limited data that describes the effects of these drugs in the presence of pulmonary hypertension, and any effects to the pressure in the highly specialized pulmonary vascular bed can aggravate an already precarious condition, which can lead to severe consequences, including pulmonary edema, cor pulmonale, and even right heart failure. This makes the treatment of postoperative arrhythmias and pulmonary hypertension significantly more complex because the side effect of every medication needs to be considered before use. This brings us to the aim of our study, which is to characterize the in vitro pharmacological effects of amiodarone and digoxin on the human pulmonary vasculature, and thereby qualify if they may be safe to use in patients with both postoperative arrhythmias and pulmonary hypertension. In our study, we used a state-of-the-art multi-wire myograph to conduct our experiments. This image shows a close-up of the myograph chamber, which shows a pulmonary arterial ring mounted on two separate pins. And between these two pins, one is fixed and one is movable so that we can apply the required tension on the pulmonary vessel. The myograph is then connected to a PC, which uses a specific software known as lab charts to measure and record the dynamic tension of the pulmonary ring. The pulmonary arterial tissue we used was acquired from lung resections of patients undergoing lobectomies. And so far, we've used tissue from a total of 5 patients in our trials. And of these 5 patients, we dissected 20 pulmonary arterial rings. And at the beginning of each experiment, these rings were mounted onto the myograph, as we showed earlier, and allowed to equilibrate for an hour. And from previous experiments, we determined that the optimal resting tension was around 1.61 gram force. At the start of the experiment, we used prostaglandin factor 2 alpha to pre-constrict the pulmonary arterial rings. And after this tension equilibrates, serial dilutions of amiodarone and digoxin are added and the dynamic tension measured by the myograph. At the end of each experiment, the reagents are washed out and the viability of the pulmonary arterial rings are verified. To test the integrity of the endothelium, acetylcholine is used, and to test the contractility of the vessel, potassium chloride is used. These graphs show the cumulative response curves of a single pulmonary arterial sample. The y-axis here indicates the tension of the vessel, and the x-axis shows time elapsed. Serial dilutions of the drugs are added when the effect of the previous dose reaches a plateau. The downward slope of the first graph indicates a reduction in the vessel tension, i.e. a relaxation of the vessel in response to the amiodarone. The graph of digoxin, on the other hand, is relatively flat and does not show any obvious constriction or relaxation. These graphs depict the average active tension on the y-axis, which is the difference between the tension under PGF2 alpha and tension in response to the drug, against the log concentration of the drug in the x-axis. The slope of the curve in the first graph shows a significant decrease in the vessel tension in response to amiodarone. However, immediately you may notice the relative lack of relaxation in response to digoxin. And even after several trials, digoxin showed neither significant constriction nor relaxation. Essentially, our study demonstrates the in vitro effects of clinically used antiarrhythmics on pulmonary vasculature. And from our results, we can say that amiodarone exhibited an overall vasodilatory effect, whereas digoxin had a relatively neutral effect. We can't say from the results of our study that both amiodarone and digoxin may be safe to use in postoperative arrhythmias. However, the work in this area is still ongoing, and we may need to do further experiments and clinical trials to confirm these results. Thank you for listening.
Thanks very much, Rishabh. A very good presentation. And we're opening to questions. And I think Betsy had one, but Pharah's got one as well. So, ladies, you take it away.
Betsy.
Oh, thanks, Pharah. So, Rishabh, I've heard you talk before, and I just want to know, you've taken samples from a lung specimen from a resected pulmonary anatomy, and you're translating this drug usage on a sample from a lung specimen to use safely in a cardiac surgical patient with potentially pulmonary hypertension. So this is the quandary I have, is you're extrapolating from a completely different group of pulmonary arteries to the ones that we see in cardiac surgery that are often fixed pulmonary hypertensives. So how do you equate your conclusions?
Yeah, that's a really good question. Just quickly, can you guys hear me okay?
Yes.
Yeah. Okay, yeah. Great question. So I think first thing we have to consider is that this is just the beginning of this line of work, and it was just an in vitro study. So just to sort of gauge what kind of effects these drugs have. So that's why we decided that that element of consideration we would neglect for the time being when we conducted our experiments. And secondly, I think often with thoracic patients and cardio patients, the comorbidities and pre-existing conditions often overlap quite a lot, which means that the pulmonary vasculature might be quite similar. Another thing is that we did use prostaglandin to pre-constrict the vessels, which was aimed to simulate the prostaglandin-mediated vasoconstriction that you would see in patients with pulmonary hypertension. So although it wasn't a heavy consideration in our project, we did try to account for it as much as possible. And obviously, we can't get pulmonary tissue from healthy patients who didn't need resecting. So
no, but you
could
get pulmonary tissue from people who put pulmonary artery vents in during cardiac surgery.
I think probably thoracotomies happen more frequently than procedures like that. So I think it was easier to get that done from where we were conducting our experiments, essentially.
Or lung transplants for people who actually have pulmonary hypertension would be a really good group to look at, is what I was going to say.
Agreed, yeah. I think considerations for continuing work in this area.
Yeah, thanks, Karen. I think you, both Betsy and you, make excellent points. So I've just got two questions. One might show my ignorance, but is this a novel finding, Rishabh?
It's not something I'd come across in literature in terms of examining the effects on the pulmonary resistance of these drugs. But I think there are guidelines that show that these are the drugs that we use, but nothing to evaluate the basic science safety or the in vitro effects.
You're saying it's novel, okay. And just out of interest, this is obviously a lab-based project, and it's great that people are doing basic sciences, all good. I know Professor Lubani is listening in, so he'll no doubt be cheering in the background. What stage of career are you? Because there's lots of people listening, and this is a bit of a sidetrack about saying, how do I get involved in research, etc. So I'm going slightly off piste, but what stage are you at, and how have you got involved? This for our attendees to know how they can potentially get involved in projects, please.
Yeah, actually, good that you mentioned Professor Lubani, because he is my supervisor on the project.
You won't get extra points for knowing him, but
yeah. So, well, the way I got involved was basically I was interested in doing a cardiothoracic project for my student selected component at university. I've always been interested in cardiothoracic surgery, and basically I approached different surgeons in the hospital where I was based, so in Castle Hill Hospital in Hull, and basically this project basically stood out to me the most, and it was something new. I know I could always get involved with clinical research.
Okay, so thanks. So how did you fit it in with your clinicals? I think that's what people want to know who are in the audience, the students in the audience.
Yeah.
Briefly.
Yeah, I think it is hard. I'm not going to lie. These experiments do take a lot of time, and they can't be done from the comfort of your home, obviously, or from computer. It does take time. Unfortunately, I can't say anything except that you have to put in the time in the lab, and you have to chase what you want to do. There is no easy way out, unfortunately. And yeah, I did spend hours. Yeah.
Just to reassure you as well, we won't deduct points for having Professor Lubani as your supervisor either, don't we?
Absolutely. He does not factor into the marking at all.
Right, Rishabh, thanks very much.
Thank you so much, everyone.
Yeah, interesting talk. Thank you. So we'll move on to our next presentation, and we should have Amila Khan with a 5-year propensity matched outcomes of minimally invasive versus conventional isolated aortic valve surgery.
Amila. My presentation is on 5-year propensity-matched outcomes of minimally invasive versus conventional aortic valve surgery. Aortic stenosis affects around 5% of those over the age of 75 in the developed world. The treatment of symptomatic severe aortic stenosis is aortic valve replacement, AVR. Conventional AVR is performed via a full stenotomy, but in recent years, minimally invasive approaches have been introduced, showing benefits such as less blood loss, postoperative pain, overall hospital stay, and similar survival compared to the conventional approach. Looking at these two images, it is clear that the minimally invasive AVR has a limited access compared to the conventional approach, which explains why this procedure is more technically challenging. The objective for this study was to compare the outcomes of patients who underwent either conventional AVR or minimally invasive AVR via an upper partial stenotomy at our institution. We included patients who underwent isolated AVR between August 2015 and March 2020. This totaled to 653 patients, of which 137 had the minimally invasive and 516 had the conventional procedure. Analysis of the preoperative data was done to determine if there were any significant differences in patients undergoing either procedure. Using the preoperative characteristics, patients were then propensity matched, and a total of 114 pairs of patients were obtained. Using the post-match groups, intraoperative, postoperative, and follow-up echo data was analysed. The mean and standard deviation of continuous data and percentage proportion of nominal data was calculated. P-values were also calculated to determine significant differences between the two groups. Looking at the preoperative characteristics, we found that a significantly older patient group underwent the minimally invasive procedure. The mean age of the pre-matched minimally invasive group was 71.3 years compared to 68.5 years for the conventional group. We also found that the mean left ventricular ejection fraction was greater in the minimally invasive patient group, with a mean of 54.4% versus 52.6% in the conventional group. Finally, a significantly higher percentage, 73.7% of the minimally invasive operations were performed by consultants, compared to 59.1% of the conventional procedures. In terms of intraoperative differences, the minimally invasive group had significantly longer cardiopulmonary bypass times compared to the conventional group, with a mean of 94.4 versus 83.1 minutes. Significantly larger valves were implanted into the patients who underwent the minimally invasive surgery, with a mean of 22.8 millimeters compared to 22 millimeters for the conventional group. The conventional group used mostly antegrade and mixed antegrade retrograde cardioplegia infusion modes, whereas all the minimally invasive procedures use the antegrade infusion mode. Early postoperative results, including return to theatre, deep sternal wound infection, new postoperative stroke, need for hemofiltration or dialysis, number of patients deceased at discharge, and length of hospital stay were comparable between the two groups. Mid-term echo follow-up results found that the minimally invasive group had significantly smaller mean aortic gradients compared to the conventional group, with a mean value of 13 compared to 17.3 millimeters of mercury. All other complications, including poor left ventricular function, significant paravalvular leak, aortic regurgitation, large pericardial effusions, and number of reoperations, were comparable between the two groups. Mid-term survival, shown using a Kaplan-Meier graph, found no significant difference between both groups. At 3 years, 92.1% of patients who'd had the minimally invasive procedure and 88.6% of those who'd had the conventional procedure were alive. The positive outcomes of this study were that despite longer cardiopulmonary bypass times in the minimally invasive group, which previous literature has explained to be a cause for worse outcomes, our outcomes were comparable between both groups. Minimally invasive AVR involves a steep learning curve for surgeons, and a smaller incision makes it more technically challenging, so it was not surprising that a greater number of the minimally invasive procedures were being performed by consultants. The next step for this study would be to collect long-term follow-up data, ideally with a larger patient group being analysed regarding the echo data, as we were unable to access all data because patients were followed up at different centres. Thank you.
All right. Thanks, Amila, for a lovely presentation. I think we're going to go to Karen first for your first question.
Amela, yes, just to say, I thought that was really well presented, well done. I just was noticing the slightly larger size of valve and the minimally invasive patient options. I just wondered, did you look at the types of prosthesis that were used? Were they more likely to use rapid deployment in the minimally invasive group as compared to the conventional group?
Yeah, so we did look at the sort of valves that were used. We looked at whether they were sutured. We divided the group into whether it was sutureless and sutured. And of the in the minimally invasive group, there were more sutureless valves being placed, and we did have a significant difference in that. And we did think that maybe that could be a reason why the gradients were different. Yeah.
And sorry, just I wanted to highlight then in the gradients, I think I maybe missed that, but what was the difference between the two then? Was there a statistically significant difference in the gradients postoperatively between the two?
Yeah, so in the minimally invasive group, there were smaller mean aortic gradients postoperatively, yeah.
Do you know roughly what the numbers were?
It was about 13 in the minimally invasive and 17 in the conventional group.
Okay. Okay, thank you very much.
It's okay.
Betsy, yeah.
Can I follow on? So you propensity matched your groups. Were they done with regards to size of aortic annulus preoperatively?
So we did propensity match based on preoperative characteristics. We didn't match it based on the size of the aortic annulus, but we did look propensity match based on BMI, which we thought would sort of correlate to the annulus. We didn't necessarily go for the aortic annulus itself, no.
No, because you might find that you actually had bigger valves that were being selected for minimal access groups.
Yeah.
But that was an excellent answer, by the way, Amelia. Well done.
Thank you.
And can I ask, does BMI correlate with size of annulus, in your opinion? Because I have my views on this, because I think I probably have a small annulus, but my BMI is bigger.
I'll be honest in that I haven't done a lot of research into whether BMI correlates with annulus. It's just that when we did get this result and I spoke to my supervisor, he did say that, you know, we did propensity match based on, for example, BMI. So it was unusual that we got a difference in results. I, however, have not done any further research into that, but that's definitely something I could do. Yeah.
PSA, have a look at PSA.
Just my own understanding and ignorance now being a thoracic surgeon, when you work up the minimally invasive AVRs now, you're doing extra imaging? Because I remember back in the day we used to just rely on the usual sort of imaging that we had, sort of echocardiograms, things like that you do for a normal AVR. And obviously with the advent of TAVI, you have more radiological imaging that we use. So what do you do for the minimally invasive ones?
Sorry, do you mean in terms of follow-up?
No, as in preparing for surgery. Yes, and planning.
I'd have to look into that. I'm not entirely sure whether more is done for the minimally invasive group, but I'll definitely look into that.
Okay. Do you remember, Amila, did they get a CT scan, for example, beforehand?
Yeah, we didn't. I can't remember us doing that back in the day, but I mean, it's been years since I did aortic valve surgery. So.
I think it is more common now, definitely.
Yeah.
But yeah, because I was going to ask Betsy how you know you. I mean, we don't necessarily rely on the echo for annular size.
Okay. Again, I'll have to have a look.
Okay, thank you.
No, but absolutely well-fielded answers.
Yes.
Thank you.
And really well presented.
Yeah, well done.
Thank you.
Okay, so we'll move on to Shaylee Mehta now for I think our final presentation, and this is going to be on establishing best practice for reopening minimally accessed cardiac surgical cases.
And I'll be talking about establishing the best practice for reopening minimally invasive cardiac surgical cases. So STS released guidelines on how to manage patients after a cardiac arrest, but no guidelines on patients that bleed after the surgery. So we did some research and we found that 2 to 7.2% of mitral valve surgeries and 3.8 to 7.8% of aortic valve surgeries might have this complication. So this highlighted that we need evidence-based practice for better outcomes. So we wanted to improve this guidance by doing this research. So STS recommendations for cardiac arrest involve 3 things. So ICU staff need to be aware with written protocol of the surgeon's preferences for management. Options can include sternotomy in ICU, operating room, or ECMO. And patients who arrest need to go for full sternotomy after following STS's protocol and should be done by experienced clinicians. And an acceptable alternative is an ECMO. So what our study aimed to do is 3 things: analyze the variation in practice in rebleeding cases and cardiac arrest cases, optimize patient safety, and to establish a practice guidance. So we did a cross-section study by sending out an online questionnaire to cardiothoracic surgeons in the UK, and we inquired about minimal invasive surgery on mitral valve and aortic valves, asking these 3 main questions: reopening strategies in rebleeding or cardiac arrest, local protocols, and personnel available overnight. So the results show the following. In rebleeding cases, surgeons mainly opted to reopen the original incision, but in cardiac arrest cases on your right showed that surgeons normally opted for full sternotomy, but you can see there is a variation practice though. So other results I wanted to share is the cardiac ITU personnel in the pie chart on your left. So this varied from having cardiac surgery registrar and anesthesiology registrar on the unit overnight in case of emergencies to maybe just a nurse practitioner. And the second thing I wanted to highlight is a consultant available in these emergency cases, with around only 28% of consultants available actually familiar with the technique, and 72% not being familiar with the technique used. I also wanted to highlight that only 39% of these units had a trust guideline to follow for the staff in case of these emergency cases like cardiac arrest or rebleeding. And only 78% had a power saw available in these emergencies, and only 26% of the units can actually say that we can get into a theater within 15 minutes if needed. So, and these were all recommended by STS to have to have a written guideline, to have a power saw available, and to be able to reach a theatre within 15 minutes. So to conclude, we wanted to demonstrate the awareness of additional guidance on top of STS guidelines, and we recommended that first approach for a bleeding patient would be to reopen through the original incision. In case there's a cardiac arrest and other reversible causes have not been identified, go to stenotomy. And there should be a power saw available in case of an emergency. And this was demonstrated using the results we just showed you earlier. So these are my references, and this concludes my presentation. Thank you so much for listening.
Okay, thank you very much, Shaylee, for your presentation. We're going to open to questions.
Hi.
Go ahead, Jill.
Hi. So first of all, just to say, we've had such a lovely range of topics demonstrated under the guises of audit, quality improvement and research today, which is really nice.
Yeah.
This is a lovely piece of improvement science research that you've done. Just to say though, you've said your #1 guideline is for the patient to be reopened by the incision that was used for the procedure. Is that right?
Yeah, that's only for rebleeding cases.
Okay, but you also mentioned that a lot of the time the surgeon who performed the procedure isn't immediately available, and also that there are a different makeup of staff, so often nurse practitioners, etc., who are covering those units.
Yeah.
So can you think of any challenges that there might be, particularly for those groups, that we don't see in the same way as the CALS standardized procedure?
So you mean in terms of availability of staff, like how to overcome those?
Yeah, so I think you've highlighted quite nicely that we have quite a good, recognizable, standardized protocol for reopening patients, usually by stenotomy. And we have lots of people trained to do that and who practice doing that. But that might not be the case if you're reopening via hemistenotomy or right anterior thoracotomy.
Yeah, so actually before this, before submitting here, me and my supervisor presented this issue on the floor in the BizMix conference in person. This was around 1.5 years ago. And it was really interesting to see the debate unfold. So there was a huge range of opinions given that most surgeons actually go for reopening the original incision rather than doing a full stenotomy to save time. So that's why we figured that this is a bigger issue rather than we originally thought. So there definitely has to be additional guidance into guiding new surgeons to the field regarding this. So yeah, that's what we felt.
And so I've had those discussions as well myself in units, and I just wonder what your thoughts are about this gap between surgeons and teams practicing minimally invasive surgery but not having a plan for reopening or for cardiac arrest. What do you think has contributed to that, or how can we overcome that? Why haven't we got that guidance in place already?
Because me and my supervisor thought that these cases are sometimes not even recognized, like they don't even recognize the need of additional guidance, is what both of us thought. So that's why we wanted to put this problem forth and research it more. We think that every surgeon is different and what they want out of a team is different every time. So it should be up to them to give that guidance to that staff in case of an emergency, because it varies from surgeon to surgeon, patient to patient. So yeah, but definitely surgeon to surgeon is what we thought.
So I think time's up, so you don't have to answer all of my next questions about how we're not all different, standardization is good, and individual decisions in emergencies. But we're out of time, so that's lucky, isn't it?
Thank you, Kelly. And Melanie, do you mind if I just bring us back to Simonette?
No, that's what we've got to do, isn't it? Yeah.
We really owe Simonette some of our time. and the Q&A. So if you can join us, Simonette, that'd be great. I know she's been having some issues with the internet, so we will wait a few minutes. Okay, well, while we're waiting for Simonette to join us, because I think it's really important that we give the opportunity to answer some questions on her presentation, I just wanted to sort of maybe echo what Jill has already said, in that this has been a really amazing session. I'm just impressed with the breadth of the work that our student colleagues are undertaking, supported by their consultant colleagues. We've been to cardiac surgery, thoracic surgery, we've had basic sciences, we've had audits, practical things, quality improvement about blood transfusion. We've even had stuff about gender representation, which I don't think is going to be an issue in this session, so we're okay. I can see Simonette is trying to come in. Are you there, please? I guess that we're still having some issues, but I just want to let everybody know, including Simonette if she's listening, that this will not be marked down against you, because clearly these are technical issues that we have been experiencing, so we'll make sure that you're not marked down for not being able to attend the Q&A. So from my perspective, I think this is really exciting. We've had, we're coming to the close of the day, and I know my colleagues are totting up the answers or the marks for the scoring that we've all been doing while we're listening to things. But as I said, the day started off with anatomy. We've had perspectives from different colleagues of how their careers have gone. People have been very generous with their time. But really, this is also such an important thing, not because it's marks and points on your ST1 applications, but because without looking into research and doing audit and quality improvement work, we're not going to get better. And it's really important that we look at ourselves, see what we're doing, and we can actually improve what we do, because there's no point doing something day in, day out if we're not reflecting on that. I don't know, Melanie, if you want to say, as you were the main chair of this session, whether you can want to say a few words about the quality of the research. And
I've been massively impressed by everybody. I mean, not only to come and present at this meeting, albeit it's a virtual meeting this year, but still to be able to do that at that level as a medical student is an amazing feat to do. And I think also having the time to put this in on top of your normal studies. I don't remember ever having spare time as a medical student, so I think they've done an amazing job. And I think any other students in the audience who are listening, see what your colleagues have been doing and learn from that and take that on, because all the units around the country will have, consultants that are willing to take you on and take you under their wing, and hopefully give you projects that you can actually undertake, and hopefully, get something out of, whether it's an abstract like this or actually a paper or a bit of research, and you should take that on board. So well done to everybody who's participated today, and well done to who chose the abstracts as well, because I suspect that was a very hard job. So well done.
It wasn't easy. There were excellent abstracts, and it was very hard narrowing it down, just as it was narrowing down our committee, and inaugural committee. Debbie and Betsy, I'm going to ask you to say a few closing words for this session before we're joined by Karen again. So pick who goes first.
Debbie, you go first.
Just to say a big thank you to everybody. I echo what the other chairs have said. Actually, I think it's been excellent quality, and I think the future is bright for cardiothoracic surgery. Looking at the looking at all of the medical student involvement we've had today. I think it's been really excellent. So well done, everybody.
Yeah, I ditto to that. It's been a really good session, and obviously some challenges with technical sides, but I hope everybody's enjoyed it. I thoroughly have.
Yes. Yeah.
And I've learnt lots. And Jill, do you want to add anything to the conversation, especially for the abstracts? You've joined us throughout most of the day, actually. So what are your thoughts of the day?
I'm just frantically adding up scores. So apologies if I can't add and talk.
No, that's the most important thing.
What I was going to say is, if anyone does have any final questions, things they wanted to ask us just while we're adding up scores, and yes, we're buying time, but pop them in the chat and then we can always answer those at the same time.
Absolutely. Slido is still open, and we still have a lot of people, both attendees and colleagues in the audience, and as you can see, the panel. So this is your chance to ask anything. And I'm scrolling through the attendees, and I'm just still overwhelmed by how far and wide our colleagues are. You know, we've got Algeria, we've got Moldova again, we've even got Wales, but you know, here that's technology for you. So while we're doing it, I'm just going to give my reflections of the day, if that's okay. So I think we're in a really our new normal, and I think I'd really like to thank, if we go through the day, I'd like to thank Joseph George, who's coming up to his exit exams, the FRCS CTH, who put together a phenomenal presentation on not just anatomy, but operative techniques and operative sort of angles of what you'd see and why you see things, and including a lot of congenital stuff, which is his interest. And he put that together while he had a lot of other stuff going on. So again, a little bit like the colleagues who presented here, you're doing this alongside your day job. So that's really great. We then moved to, I'm going to remind myself what we moved to. We then moved to really heartfelt presentation from Charlotte Holmes, who talked about her journey navigating a career in cardiothoracic surgery and shared her top tips. And I think one of my comments from the back of that, apart from to thank Charlotte, was that it was a really, don't panic. There was so much information in there, but you can just find it very easily on the Wessex Deanery. And on talking about websites, SCTS has just launched their new website, which is really, you know, a pleasure to navigate now, and hopefully you'll be able to find all the student information and trainee information. And then we had our inaugural University Challenge, and I'm still quite frightened to say University Challenge in case we get a challenge from the BBC, but it was Karen who did that. So it was Karen and Pharah's University Challenge, and thank you for Kirsty for navigating that. And our very own Bamber Gascoigne, that's the one for the older ladies, or Jeremy Paxman, who are hosting it. So the president tried to make it entertaining. I've promised him, he did complain to me afterwards that there was no music round, so I blamed Karen. So there was a couple of questions of how were the teams chosen? And clearly we had tight timelines, but for next year, we are going to make sure that it's open to all universities, and we will have a few rounds going ahead, and we will do a music round. I'll give you the question for the music round. It will be it'll be Tina Turner, Simply the Best. And the question is, which consultant cardiac surgeon comes off bypass to this tune? I know the answer. It's not me. I don't have music in I'm far too serious for that. So that's the question for next year. So after that, that was really good, and we will develop it, and it will be inclusive. And then my thanks, or Karen and my thanks to Betsy, or Ms. Evans, Ms. Harrington, Ms. Hardman, and Ms. Jenkins, who are all on the screen, for their sort of generosity of time to answer questions about their thoughts and careers, tips, etc. And I think, and of course, we heard from Simon, or the president, as I prefer to call him, about the future of our specialty. But really, I think Simon was focusing on how it was for him in terms of training, and I think it was good that we focused on training because you are the future of our specialty, and we need to help provide you with some signposting. And I think possibly one of the highlights, there were so many highlights, I can't really say highlights, can I, was listening to Michelle McCaffrey, because we all talk about when we apply for jobs about why we did it. And I was traumatized at a young age, which was my story, or I do this for the patients, but really hearing from a patient who was going about their daily life. And it's not often our elderly patients that we see with their aortic stenosis or coronary artery disease and they've had angina pneumonia, but really to see somebody whose life was so dramatically impacted by their condition and by the really almost miraculous sort of intervention that people can do. And it wasn't just about the amazing stuff Karen and her team did, but that picking things up, which always reminds me for the students in the audience about thinking about aortic stenosis, not aortic dissection, because it's often the first person who remembers that and was taught that at medical school and thinks about really severe pain, worse they felt through the back, that picks up the diagnosis. It's not all the fancy stuff people do in the bigger centres. It's picking up these conditions. So I think without our patients and their stories, we're poorer for it. And finally, the presentations that I think I've already said that the presentations have been amazing, varied quality, basic sciences, quality improvement, cardiac and thoracic. And I'm now going to hand over to Karen seamlessly. And I hope, I do not know what the answers are. So everyone was really, really good. I will value all your input. And I'll hand over to Miss Booth to reveal the person who succeeded. But before I do that, please, if you're registered for the rest of the meeting, please do attend the Equality and Diversity session, and where we'll be introducing the new Women in Surgery team, of which Miss Booth is chair, and everyone on the screen except me are on the inaugural Women in Cardiothoracic Committee. And don't forget the big quiz, otherwise Sunil will over to Karen. I'm going to stop now.
Yeah, so this is incredibly apt, and I think all the students will appreciate that I double-checked and triple-checked all the scores and made sure that they all matched and had your names correct, which is what we were trying to do while that was ongoing. But everybody on the screen is part of the new working group for women in cardiothoracic surgery, and so it really gives us great delight to say to Rhea Patel, if she'd like to come onto the stage, that she is the winner of the Pat Magee session for the scientific abstract. So Rhea, would you like to come up?
And it wasn't a fix.
But I did get some of the names wrong and have to check it twice.
Thank you. Can you hear me?
Yes, we can. Go ahead, Rhea.
Thank you so much for that. It really means a lot. And yeah, it was honestly, again, following from what you guys said, such a pleasure to listen to everyone else's abstracts and submissions as well. And it really has been the most interesting day. So thank you very much.
No, congratulations to you. We'll be keen to see what other bits of research come out from you in time when you come and present on other sessions with us. So that's great.
Yeah, many congratulations, Rhea. And I think that sort of wraps up the session, but I'm going to give the final word to Karen.
Yeah, so just on behalf of Pharah and I just want to say thank you so much to all the speakers, to all the students who clearly put in an awful lot of hard work. There's some really great work going out there. I know I scored all the abstracts, and I can tell you that actually it really wasn't easy to select who the top 10 were, and we had to move some out into other sessions because the quality was so high. So please, we hope we've inspired you today. We hope that after all this, you'll hope to come and join us and be the leaders of the future. And I wish you a very successful SETS 2021.
Well done, everybody, and good luck. Carry on the good work.
Mm-hmm.
Bye.
Take care. Bye.
Take care. Bye.